So thank you for joining us today. You're going to be learning about a new collaboration between the U and the Mayo Clinic to address COVID-19 transmission through laboratory experiments and also surveys through the Well Living Lab. I'm going to introduce the lead scientist on this project to address COVID-19 transmission, Dr. Zachary Pope, and he'll be kicking things off for us. He received his PhD in kinesiology from the U. And then he did, for a couple of years, T32 postdoctoral NIH fellow in our division of epidemiology and community health. That was on Aaron Folsom's cardiovascular disease training grant. As long as I've been here, Zach has been one of the most productive, energetic postdocs I've ever experienced. So I could go on and on and on, but we're not spending a lot of time on introductions today. But he's just the perfect scientist and has got a great background. I will just quickly say that when he went to the Well Living Lab, he didn't realize he was going to be doing experiments on this virus. And he's a quick study, to say the least, and has assembled an extraordinary team, as you'll see this morning. So Zach, since the midsummer, he's been the research scientist in physiology and behavior at the Well Living Lab, which is a Delos Mayo Clinic collaboration, and he's now also an assistant professor in physiology at the Mayo Clinic. So Zach, take it away.
Yeah, thank you, Mark. Don't know if I quite deserve that much of an introduction, but I really appreciate the opportunity to be here. Just give me a second here while I share my screen. All right. Yeah, so thank you again all for attending today. I'm just going to be brief with this introduction before we kick things off. We all know that the COVID-19 pandemic has really created an unprecedented challenge for individuals worldwide across multiple parts of our lives. Until we have a vaccine that's widely distributed and just as importantly taken by the majority of the population, we're still in for a long road here. And we do know that the asymptomatic spread of SARS-CoV-2, the virus, as you all know, that causes COVID-19, contributes to many of our COVID-19 infections. Notably, the SARS-CoV-2 virus spreads most easily indoors, and thus the impact of indoor spaces on our health and well-being has really become more important than ever. With that in mind, and in response to this critical need, the Well Living Lab announced in April 2020 our COVID-19 and Beyond Well Living Lab Safe Indoor Environment Program. And just really having been involved since that time, this has just been a wonderful program to be a part of and lead. I would push back a little bit on Mark's assertion that I was the one that assembled this team. It's really been a group effort. But before we get into the science, I'd like to first hand it over to Barbara Spurrier. She's our managing director here at the Well Living Lab, and she'll just give a very, very brief overview of what the Well Living Lab is and how it formed, and then we'll get right into the science. So Barb, I'm gonna hand things right over to you.
Thanks so much, Zach, and right on to our first slide, please. It's such an honor to participate in this seminar, and our greatest honor to be collaborating with the University of Minnesota. So the Well Living Lab launched just over 4 years ago, as mentioned, a collaboration of two pretty amazing organizations, Delos and Mayo Clinic. You know the great Mayo Clinic, perhaps Delos is new to you. Delos began just over 10 years ago with a really big idea that we spend over 90% of our time indoors, and the indoor environments can influence almost every aspect of our lives, from how well we sleep to our performance throughout the day. And Delos started a movement bringing research and evidence-based innovations to transform our built environments into vehicles for health and well-being. So as we see with the Mayo Clinic and the health science and Delos as the building science, is such an awesome foundation for our Well Living Lab. And this is to advance on the next slide, our mission. So our mission in transforming human health and well-being in the indoor environment, and our priority environments of healthy office, healthy home, and healthy communities, with a focus on healthy aging and senior living. So on our next slide, I'm very, very proud to share our accomplishments that are highlighted here. We've completed 15 studies and we've published 12 peer-reviewed publications over the last 4 years. We're building a Well Living Lab global alliance and ecosystem, if you will, with such phenomenal companies like Ford and 3M, Panasonic, KB Home, and many others. And all of this has really been made possible with our multidisciplinary team that's just incredible. We have about 23 people from Delos and Mayo Clinic, scientists, research analysts, physicians, technologists, project management, communications, study coordination, lots of things, as we know, to be able to execute around our lab priorities. Our team expanded earlier this year as we announced our first academic collaboration. So we started with the best. We could not have made a better decision than to partner with the University of Minnesota. We're so excited for the current work that we'll be highlighting today and for the future as we partner together to advance our mission of improving human health and well-being in the indoor environment. So at this time, I'm thrilled to turn the program over to Dr. Veronique Roger, who serves as the research director of our Well Living Lab, a Mayo Clinic physician, scientist, epidemiologist, and many other things. So Veronique.
Thank you so much, Barb. Good morning. It's great to be here, quote unquote, and looking forward to sharing a little bit with you how we got to where we are. I'm not going to spend hardly any time on this slide in front of this particular audience who knows this better than perhaps any group in the United States and the world. I just want to say that when we started working on COVID-19 in April, as Zach mentioned, and as you will see a little closer, we just didn't realize the magnitude of the public health, clinical, and sanitary crisis that this country would be facing. And so sadly, the work that we started a while back is increasing in relevance as the country goes forward. So next slide. So the approach that we took since I joined the Well Living Lab as research director was really to figure out a way to do the best in class science with a mighty but small team. And so we recognized, obviously, that any research that we would do in the Well Living Lab, but particularly research on COVID-19, would require a highly multidisciplinary and collaborative approach, which is easier said than done, as you all know, in terms of scientific collaboration. The key being to identify a domain where there's a sense of win-win, if you will, for both parties involved in the collaboration. It was a natural thing at the time, particularly for me, being a proud alumnus of the University of Minnesota School of Public Health, to turn my first academic inquiry to the University of Minnesota and to contact Mark and Jesse Berman and Zach. And I still remember that day when they came down and visited the Well Living Lab. I don't even know how many months ago that is, but it was really the first step of what turned out to be an exceptionally fruitful collaboration, as was mentioned. When we decided to turn our attention to COVID-19, we met with a group of experts, several from the university, of course, and others from our scientific advisory group, which is an external group of high-profile scientists in various fields related directly to health in the indoor environment, which is the focus of the lab. We met on a Sunday morning. I like to say that because people were just on Zoom on a Sunday morning from 9 to 12 or 1 or whatever, with really attesting to the commitment that all of us in working in science experienced at the time, not only with this collaboration, but across all the collaborations that were all involved, with the sense of urgency that this pandemic early on triggered. And these meetings led to develop of 3 high priority interrelated aims, which are described on the next slide. So the idea was, in general, to generate evidence to optimize the physical and psychosocial conditions of the indoor environment of the COVID-19 era. And we recognized that there were 3 buckets, if you will, acknowledging a certain degree of oversimplification, but 3 buckets that included air, surface, and behavior. So with regards to air, it's interesting that as we were formulating, and of course, Chris Hogan will talk about that in much greater details, but when we were formulating our line of our conceptual framework and line of thoughts around air, back then we were still talking about droplets, and there were still some back and forth along all the stakeholders and scientific authorities around the nation and the world discussing the issue of aerosolization of the virus and whether or not it was a problem. And it's interesting to have seen really science unfold in front of our eyes as we were working on this. Second point is surface, which is to examine the best modality, if you will, to provide surface disinfection, both in the office environment, but of course it applies to other environments, including home and potentially transportation, cars, etc. And then finally, the third bucket that we call behavior really includes the ability for all of us really to adhere to key measures that are paramount to protect ourselves against COVID-19 and that are anchored in our own personal behavioral choice, wearing masks, and there's no need to elaborate around the controversy that this has created, as well as hand and surface disinfection and hand washing and surface disinfection. So these are the three domains, if you will. Now, as you can understand readily, these domains are interrelated because the common denominator, if you will, is COVID-19, but they call for very different scientific expertise, and therefore, and that's where I actually do agree with Mark, and we'll push back on your pushing back, Zach. We assembled, we meaning Zach, assembled a team of 20 plus researchers from largely Mayo Clinic and the University of Minnesota, in addition, of course, to the Well Living Lab, to define what we were going to do, the hypothesis we're going to test, and how we would execute those three aims. Next slide. So this is just a glance at the timeline that we have worked with, just to underscore that not only was this collaboration exceptional by the people involved and their common will to roll up their sleeves and work together towards one goal with different research projects, but also because the timeline has been exceptionally compressed. And so a lot of that is, again, unquestionably credit to Zach, who has been leading this program and has doggedly pursued all the operational aspects that led to deploying the three directions, if you will, that we had identified with air, surface, and behavior. But also we were lucky that we were able to, for example, the survey that you're going to hear about towards the end of the presentation, get IRB approval across 2 institutions as a record speed. As we all know, IRB approvals are sometimes a long journey. And in this case, we were quite pleased that we were able to do this quite efficiently, both at the University of Minnesota and Mayo Clinic. So again, the timeline is here. We frankly thought that we would be reaching the end of sort of this work at the end of the year. And as we all know, we now know that this will extend quite substantially in 2021 until, as Zach mentioned, the vaccine is available and also that people are vaccinated. So 2 big milestones here that are maybe in sight, but definitely not there. We also hope that the work that's been done here is going to be, for us, if you will, a proof of concept that we can, as a small entity, reach out to the experts in the world to help us deploy such a multidisciplinary program, and that this collaboration model will extend beyond COVID-19, although this is certainly a very powerful illustration of what can be done when mutual collaborations can unfold. So I'll turn it back to Zach and look forward to the rest of the presentation.
Yeah, thank you so much, Veronique. Just moving right into the science, and I think what Veronique said as it pertains to the power of collaboration will ring true throughout, our aims here. The first individual I'd like to introduce, and he'll actually review the science, is Dr. Chris Hogan. He's from the University of Minnesota's Department of Mechanical Engineering. He's really the lead for our AIM work. He brings years of experience and expertise in aerosol science, and quite frankly, directs one of the most well-equipped aerosol laboratories in the US. He's been absolutely fantastic to work with. Stephanie Eilts within his lab is also working with us, and she's just been fantastic. She's a graduate student, and we are also working with individuals at Mayo Clinic like Dr. Bruce Johnson, as well as very talented building scientists within our own Well Living Lab, Dr. Rangpeng Zhang and Lin Hao Li. So I'll hand it over to Dr. Chris Hogan to review what we're doing for our AIR AIM. Chris, over to you.
Yeah, thanks, Zach, and I hope everyone can hear me okay. So, and also thank you for mentioning, I'll probably say we a few times in the next few slides, and by we, I do mean Stephanie Eilts, who's a graduate student in my group, who I've really done kind of a hero's effort in terms of getting what I'll show as a breathing simulator working. So a little bit of background. When the COVID-19 pandemic began, as Dr. Roger referred to, the common thinking was that a main mechanism of transmission was what was called the droplet mechanism. And droplet, to an aerosol scientist, which I am, simply means larger respiratory secretions, which will gravitationally settle out at some distance very close to the person that expelled them, and that the transmission would be through surface. As particles or droplets get smaller and smaller, which they can do to evaporation, or they can be exhaled at this size directly, gravitational settling velocities are very, very slow, such that local eddies and local motion of the flow is sufficient to keep things airborne for an almost indefinite period of time, to the point that in order to clear those particles, you do have to think about some sort of active removal measure, be it ventilation or be it some sort of recirculating air purifier. And they can deposit at much, much greater distances than you would normally think. They can disperse throughout the entire space. And there really wasn't a lot of precedent for studying this. And the main reason that this is difficult to study is that if you look at the concentration of particles, droplets, any sort of aerosol that is ejected from a person, the concentration is actually very, very low in comparison to background concentrations. We're thinking 1 to 2 particles per cubic centimeter from what a person ejects, while we're looking at probably 1,000 to upwards of 10,000 in background very clean air. And in addition, the other processes that we do, scratching, rubbing our hands together, rubbing against the surface, will aerosolize more particles than we're actually exhaling. So we have a really difficult signal to noise problem when you actually work with people. Any study that is actually looking at exhalation directly from a person is doing so in what are called clean room type settings, absolutely particle-free, very conditioned air. But we want to develop methods to study this in an office-like environment. So to do that, what I believe we've come up with is an effective in vitro experiment using simulated breathing. Of course, we don't want to be dispersing viruses of any type when we do this, but we do want to have some sort of tracer that our simulated breathing can have. And so to do that, we use one of the most sensitive tracers that can be used in environmental studies, which is fluorescence. And so what we're going to show you is our fluorescent breathing simulator that is put into the office unit of the Well Living Laboratory to actually look at exhalation dispersal in an actual office environment. And then ultimately to what influences that dispersal. So meaning, where do particles deposit and where are their concentrations higher? Is this affected by configuration of the office space? Is this affected by whether the person is masked or not? And is this affected by ventilation rates ultimately? So if we go to the next slide, I think we have a video of it. Oh, we're one slide away. So what Stephanie did to get this put together is it's a little bit of programming. And then looking in the literature to look at what the breathing pattern of an individual is. And it usually tops off around 20 liters a minute at peak exhalation rate, but then rapidly decays from that. And what Stephanie did was take what is normally a constant output spray process that we use in aerosolization and operate flows such that it is now a pulsed process while the particle size distribution we produce is constant. This is then connected to a respiratory mannequin, which is often used in inhalation and exhalation studies. And so the aerosolization source is plumbed into the airways, and so that we can actually have aerosol expelled from an individual. If we go to the next slide, I think we have the first video of it, which is on the left here. And so you should be able to see in a moment the pulsed breathing. What you see coming out of the mannequin are primarily water droplets, which are upwards of 10 micrometers, if not a little bit larger at the point of exhalation. You lose those droplets through dilution and also because they evaporate fairly rapidly. The droplets are doped with fluorescein dye, as well as they're about 20% glycerol. The glycerol is there to actually control the final size, to be similar to what measurements have told us droplets, when they evaporate completely, yield from human exhalation, which is about 1 to 2 micrometers in size. And so we're dispersing 1 to 2 micrometer particles. Each breath that our simulator takes would be the equivalent of millions of breaths in terms of particles from a person. And in this way, we can actually model dispersion within the Well Living Laboratory Office module. So it's probably easier to see if we go to the next slide. You can see a bit of the office module here, but now when put into a person's who is simulated actually sitting in this case, here you can see the breathing simulator going. And this is the office module of the Well Living Laboratory. We have most pieces of equipment here are covered. Zach, Stephanie, and the researchers doing this down in Rochester have also put substrates to look for fluorescein deposition, so we can understand transport from an aerosol to a surface where they'll do fluorimetry measurements. And in addition, we use aerosol samplers to look at concentrations throughout the room. So you're getting both air concentrations as well as surface deposition concentrations. When we combine those, if we go to the next slide.
Sorry, Chris.
Yeah, no problem.
There we go.
Yep. When we combine those, so when we go to the next slide, we look at the concentration in the air. We control the size distribution that we're exhaling, and we modulate the office conditions in terms of configuration and ventilation rate. We can start to understand clearance times, deposition rates of particles, as well as how these are affected by how we control our indoor environment. We're also not looking at air and surface as an either or prospect, but an air and surface together. To be more specific on that, I think the last thing I want to show is on the next slide. We can actually talk about deposition hotspots in a room by combining measurements of particle concentrations or mass concentration of aerosol in the air, which is done through a standard liquid impinger sampler, and through really honestly using saran wrap as a deposition substrate from which we can extract fluorescent dye and get at what's called a deposition flux. So deposited particle mass per unit area per unit time. From getting the concentration from the impinger measurement and the deposition flux, the ratio of those two gives us a dry deposition velocity, common parameter used in ambient aerosol studies to describe where particles are depositing close to a source. We can now do this locally in a room environment and look at things like if we're close to the air intake or the air outtake, does that influence the exposure in that environment? And so that's really where we are in terms of air. Which I believe will lead us right into surface when we look at the next slide.
Yeah, so before that, and thank you so much, Chris, wonderful overview. And I think it's probably apparent why we love working with Chris and his graduate student, Stephanie, who again has just done such a wonderful job putting everything together as far as the breathing simulator is concerned. You know, the current status where we stand right now is we're conducting pilot studies to refine the procedures that Chris just reviewed. In fact, as we speak, we're flipping the room right now so we can start pilots right after this presentation here. You know, projected next steps is, as is common in most research, we want to distribute evidence-based recommendations, particularly given the critical need for these recommendations really worldwide. and want to inform room operation and layout based upon the trials that we're conducting. And then we're also trying to think forward too. So what does filtration and ventilation strategies look like in the home and perhaps even vehicles? And so those are all talks and discussions that are ongoing. When we transition into our surface work, this is really led by two individuals who are just fantastic. Dr. Stacy Rizza with Mayo Clinic Infectious Diseases and Aditya Shah. Dr. Shah is actually here with us today, and he's also from Mayo Clinic's Infectious Diseases. Both of these individuals have just been wonderful to work with. They've really informed so much of what we're doing here, but we wouldn't be able to do this type of study within our own lab. So we've also had to leverage individuals from the Department of Molecular Medicine. So doctors Richard Weil and Hideki Ebihara, they have the labs that are necessary, that have the necessary biosafety level designations to work with the viruses that we'll be reviewing during this presentation. So without further delay, I'm going to hand things over to Dr. Shah to review what we're doing with our surface work. Adi, over to you.
Okay, thank you, Zach, and hi, everybody. It's nice to be here. It's just been a tremendous collaborative effort with everybody on this chat and several other people who are not on this chat to essentially understand the science behind what's going on. So in adding to what Chris said and to what Zach said, another mode of transmission of this infection is via what we call as fomites, which means if you cough, sneeze, or even speak loudly or shout loudly, then you create droplets which might be deposited on the surfaces that you are sitting on. And if somebody else touches that surface, which is filled with infectious material, and then touches their eyes, nose, or mouth, then they can be infected. So most of the studies that have been done so far, or the literature that we know, tells us that this virus can be detected on these surfaces. But what we do not know for certain is that is detectable virus actually capable of replication and infecting somebody else, and how long is it able to do that, on what surfaces, and what are the best disinfection strategies? That's where the next step of this research comes in, i.e. we are trying to understand if the virus is active on what surface for what amount of time and what can be used for disinfection. So how we're doing it is we are doing a two-phase method. We are first trying to study a non-SARS-CoV-2 virus and then the actual SARS-CoV-2 virus and test it on 3 commonly used surfaces using 2 commonly used disinfectants, one of which is a medical grade disinfectant and one of which is a commercial grade or eco-friendly disinfectant to see and test and research inactivation of virus on each surface. So moving on to the next slide, let's review these viruses, surfaces, and the disinfectants. So our first step would be to look and test for what's called as a vesicular stomatitis virus. This is a virus which is commonly found in livestock and human beings, and it is safe for humans to handle. And this virus is also able to reproduce in a large range of cultured cells. And the good thing about this virus is that we can tag on a protein to this virus, which allows the virus to glow, which helps us detect it before and after disinfection. So we are planning to test this vesicular stomatitis virus on each surface, each of the 3 surfaces that we plan to study, pre and post disinfection of those surfaces. And we're going to be working with Dr. Richard Weil's lab to complete this research with the vesicular stomatitis virus. And then the next step is to study the actual virus, which is the actual SARS-CoV-2 virus, which we will be working with a highly secured lab run by Dr. Hideki Ebihara. And we will employ refined methodology that we will develop during our work with the vesicular stomatitis virus, and then apply those methods to the actual SARS-CoV-2 virus. And it is also important to note that both these 2 viruses that we will be working with will be what's called as replication competent virus, which essentially means that the viruses we are depositing onto each surface contains all needed genetic material to infect an individual if the virus is detected in large enough quantity. So moving on to the next slide, the three common surfaces that we plan to study are stainless steel, laminated wood, and porcelain. These are commonly used surfaces in businesses, and all these surfaces are considered hard, non-porous surfaces. And while all surfaces are fairly smooth, the laminated wood is slightly grooved, as you might see in this picture. Next step, so we discussed the viruses, we discussed the surfaces, and on the next slide is where I come in my expertise as an infection prevention and control specialist, is we are also trying to see what are the commonly used disinfectants that we can use to test these two strategies. The first disinfectant would be what's called as a super sani cloth wipe. It is a germicidal wipe, which essentially is a hospital grade disinfectant, and it comprises of quaternary ammonium and isopropyl alcohol. And we are currently using that in our hospital at Mayo Clinic to disinfect patient rooms, disinfect surfaces, cafeteria tables, chairs, clinic rooms, etc. And the second disinfectant that we will be using is a commonly available commercial grade disinfectant, and which is eco-friendly as well, which is called Oxivir TB. And this is a spray disinfectant, spray-based, not a wipe-based as the previous one was. And this spray-based disinfectant is a hydrogen peroxide-based disinfectant, and it is used commonly in commercial spaces, and we will ensure that the surface is sprayed until wet during disinfection trials with each study. So next slide. Our methodology will essentially be trying to mimic actual infection methodology. And the first method would be using pipetting. And the second method would be to essentially use touch with a latex glove to mimic how a touch-based fomite creation and infection might happen. So in the first method, we will be pipetting 50 to 100 microliters of virus onto a predefined surface, predefined area on each surface, and a similar volume that have been done in past studies. And the second method would be involving the application of the virus to a latex glove, and then employ that as a single touch way of essentially inoculating these surfaces at predefined areas with a touch methodology. And we will then use to both these applications, both the pipetting and then the touch method, we will then try to employ the two disinfection strategies that we discussed. So if you remember, the first strategy would be using a hospital grade disinfectant, which is a super sani cloth wipe, which again is made up of isopropyl alcohol and ammonium chloride based disinfection. This will be a wipe. So essentially we will wipe down the surface where the virus is applied using both these strategies. And the efficacy of this wipe needs that it have a 2-minute dry time, which means that if we wipe a surface with this sani wipe, then it essentially has a 2-minute dry time or contact with the surface. And the second way, as I discussed prior, is the Oxivir TB spray, which essentially means that we'll be spraying these surfaces where we've inoculated the virus with this spray, which ensures a 1-minute contact time with the surface. These are the two ways that we plan to essentially disinfect these two ways of inoculating the virus. And the two main outcomes that we will be looking for is first step, which we know from studies done so far, is the actual presence of the virus, which means that can we detect genetic elements of the virus. We already know from past studies that there's probably genetic material that can be detected, but where our research is a bit novel is that we're going to try and find out if detectable virus is actually capable of replication and viability, which means if a virus is detectable, can it actually be grown in the lab? And if it is grown in the lab, then can it actually infect a susceptible individual? That is where the $1 million question is. And that is what we are trying to answer by these methods, using 3 common surfaces, 2 inoculation strategies, and 2 disinfection methods. So I'll hand it over to Zach after this.
Yeah, thank you so much, Adi. Really appreciate it. And, Adi has just done wonderfully to inform how we're doing this work. Just like with air, give a little bit of an update as to where we stand. Current status for this is actually with the VSV virus, so the non-SARS-CoV-2 virus. We've actually finished our disinfection trials for laminate wood, and the next 2 surfaces will be done by early December. And we're actively prepping for our SARS-CoV-2 disinfection trials with Dr. Hideki Ebihara. We'll actually be meeting with Monday to start kicking off the prep for that. And just really excited to use the methods that we've refined with VSV to then inform how we're going to more efficiently work with the SARS-CoV-2 virus. As far as projected next steps, really one of the other reasons that we've been so meticulous about the rollout of what we're doing here and the methodology in particular is because we do want to make this sort of a plug and chug methodology, if you will. So if we have a surface or additional disinfectants that we would like to then test, we're able to do that. And that's really what we're thinking about here. You know, what are further surface materials? We're looking at a lot of hard, non-porous surfaces, but what about softer surfaces? And so that is definitely something that is on our radar. And then, you know, once we think about, you know, moving forward and moving out into the field, you know, examining the use of things like touchless appliances, antimicrobial surfaces in the home or other residential environments, or even public, for instance, office space environments would also be important and of great interest to us. So moving on to just a quick plug here. I'm not going to play anything, but we were featured in early September, our air and our surface work on CBS This Morning Saturday. It was really a testament, I think, to the power of the collaboration and the timeliness of this research. But quite frankly, there's so many labs doing such great work. We really felt fortunate to have had this opportunity to really be able to showcase what we're doing. And really, even though it was at a very early phase of the research that we're doing here, really demonstrate, more importantly than anything, the power of collaboration and what happens when you put individuals who are just incredibly talented in their own domains into the same room, and we learn from one another and push forward. So the video link is included here. It is on our the Well Living Lab website if you would like to go check that out. Moving on to the final bucket, as Dr. Roger said, behavior. Behavior is obviously important. You know, the virus may end up causing the infection, but it's human behavior that ultimately spreads it around. And so it's obviously important to evaluate behavior as it pertains to SARS-CoV-2 and the spread of this virus. Dr. Mark Pereira, I've been working with for almost 4 years now, since the third year of my PhD. I could speak the world of him and all that he's done for my career, as well as Dr. Aaron Folsom. Both of them have just done wonderfully to inform how I think about studies and how things are rolled out. So Mark will be giving an overview of what we call our capture survey. Mark is a full professor at the University of Minnesota within the Division of Epidemiology and Community Health, and he's obviously the seminar director. So I'll refrain from giving too much more about Mark, since I know you all are very familiar with him and his work. So Mark, I'll turn it over to you.
Thanks, Zach. I'm going to be really efficient here. I'm going to talk about the survey that is currently in the field for behavior and psychosocial outcomes. And this is much more straightforward than the other technical parts of the project. So I'm going to try to be brief here. So we're interested with the survey in assessing SARS-CoV-2 transmission prevention, behavior awareness in the workplace, and implementation of the behaviors that people we think should be doing. And we're looking at the related perceptions and psychosocial outcomes in the workforce. So this is really broad. We're recruiting companies from the entire US who work primarily indoors, including sectors of technology, finance, grocery, transit, restaurants, and others. And it's a prospective survey, so we do a baseline assessment, and then we follow up with the survey repeated at 3 months, 6 months, and a year after the baseline. Next slide. And so the survey itself is called CAPTURE, and it stands for Characterizing Awareness of SARS-CoV-2 Prevention and Understanding Responses and Experiences. So Zach came up with a nice acronym if you're into acronyms. Next slide. So we're interested in the transmission prevention behaviors that are happening in the workplace to try to get a baseline, and then follow-ups on that over time. So we're measuring face mask wear, hand washing, physical distancing, surface disinfection, temperature checking, and other factors. And so we also are interested in the psychological impact. We know from the literature of other pandemics that there can be, major impacts on stress, anxiety, and many other things at home, but also in the workplace, and how this might affect the productivity of the workers and many other issues. So we're measuring stress, anxiety, depressive symptoms, work satisfaction and productivity, and feelings of safety in the workplace. Next slide. It's delivered on a Qualtrics secure platform, and all the data are anonymized and safely stored in cloud-based secure servers. Next slide. And then in terms of the outcomes, there are 2 primary outcomes. We'll evaluate the awareness and implementation of SARS-CoV-2 prevention behaviors in the workplace, and follow up with the subsequent time points and look at trends over time. We will evaluate the psychosocial outcomes and perceptions related to working during the COVID-19 pandemic. So when we started putting this together, months ago or a couple months ago, I don't know, time is passing so quickly, we weren't quite sure, what was going to be happening with the pandemic. And now it really seems as though we're going to be collecting a lot of really important data based on the way the pandemic is unfolding, unfortunately. Next slide. And so we started September 25th in terms of launching the survey to date to 135 companies. We've classified these companies into essential and non-essential employees based on the U.S. Department of Homeland Security's definitions. And we have currently contacted 66 non-essential employee companies and 69 essential. And we're in the process of trying to contact about 100 more companies. Next slide. So now I'm going to turn it back over to Zach. Yeah, I was trying to be a little bit speedy in the interest of time, because we'd like to have questions for discussion.
Yep, and I look forward to that discussion as well. Not too much to go through here. We have had formal expressions of interest from 17 companies, 14 of which were the non-essential companies, so they employ primarily non-essential employees, and then 3 essential. 7 companies have thus far agreed to participate, 6 non-essential, 1 essential, and total number of employees from those companies is a little over 22,000. And the first surveys for Capture are scheduled to go out next week. I think it's also important to note, again, just getting back, and I know we've said it multiple times, to the power of collaboration. We were awarded a small grant for the Capture survey from the University of Minnesota's Sustainable Development Rapid Response Grant. So it's part of their Sustainable Development Goals initiative, which again, we really could not have done this without the University of Minnesota and really the guidance provided there and the assistance provided there. As far as projected next steps, we're thinking forward. So what are the behavioral strategies moving forward? I know that the University of Minnesota, it looks like midsummer is the first time where individuals may be invited back onto campus to do their work. And so thinking about what we can do in the meantime to help with those behavioral strategies, is there signage, media, different room layout recommendations, which of course will be informed by our other study or our other aims rather, as it pertains to getting individuals safely back into public spaces like an office, and really just trying to promote the adherence and the implementation of SARS-CoV-2 prevention behaviors. But when you think more long-term, really just your seasonal flu, any type of respiratory illness, that these behaviors really map onto those quite well too. So it's obviously important in workplace, residential communities, as I've already mentioned. So with that, and to Mark's point, we'd love to open things up for questions, comments. Mark, I think that you're the one that can see the chat, and I think that it's best if you moderate that, and I can help you direct it to who might know best how to provide an answer.
Yes, please do use the chat for your questions. And if you can find the hand raising tool, I could unmute you if you want to ask a question. While we're waiting, do any panelists have something they'd like to add that they feel like was left out?
Maybe Mark, this is Veronique. Maybe I'll just ask or make one point for curious to see what you and others think. When we send all these invitations to the survey and started to look at the response that was emerging, albeit early, into essential versus non-essential, there's a clear bias towards non-essential workers, which initially was not the target population that we're aiming for. I mean, we, as you recall from early conversations, we were really interested in essential workers, particularly given the social determinants of health context, if you will, that surrounds the issue of essential workers. And so just wondering if you, Mark, or anyone would want to comment on going forward, because as you mentioned, unfortunately, we have some time ahead of us to keep exploring these topics, to perhaps oversample non-essential workers and to oversample the companies with essential workers and how we could mitigate this this emerging bias that we see in the survey response.
Yeah, I think that we could certainly target more essential workers companies. They have to, that we're only recently have we gotten out of the gate with the survey. And I think you raise a really good point. We should jump on looking at the demographics a little bit more carefully of those who are responding and see if we do want to oversample some of those sectors. I think that would be important. We can't do a random sample because they have to agree to do this, and so that's one of the challenges that we have. What we are trying to go as broad as we possibly can with this, and I think, unfortunately, the way the pandemic is unfolding, we're going to have a lot of time to collect a lot of data. We wish it wasn't that way, but I think maybe for all aims of the scientific projects that you heard about today, I just think there's going to be significant contributions to the science and the recommendations in the relative near future. Colleen Peterson is asking a question. Why is the surface study starting with a non-SARS-CoV-2 virus?
I can perhaps take a stab at that. So that is because we first want to make sure that our methodology works with a safe to work virus, which has been which has been the way with working with basic virology research. We first have to make sure that with a non-infective virus, which is commonly seen in the environment, in animals, livestock, and human beings, that we can have our steps of our research done and prove that it can be done before we handle an actual live virus of interest like the SARS-CoV-2 virus. And that's why we first do it with the VSV virus before the SARS-CoV-2 virus. Zach, you wanted to add anything to that?
No, I think you, as usual, hit on all the very important points. I think the other thing to mention more logistically, aside from the actual science itself, is that Hideki Ebihara's lab, as everyone could probably imagine, is very much in demand right now because he has access to the SARS-CoV-2 virus. And so being as efficient as possible with what we actually do within his lab is very important as well. So going in there with a firm plan that's been refined using that VSV virus is very important to us.
Chris, could you maybe talk a little bit about the external validity of your aerosol experiments and what seems like you're doing everything possible with the best laboratory approaches to mimic the real world and what's going on with the human body? What are some of the next steps to address the question that you'll get from critics, which is sort of appropriate? It's, how does this relate to real life?
Yeah. So the one thing that we're not able to do, of course, we can look, I think, pretty detailed spatial resolution because of the setup they have in Well Living Lab at where particles deposit and where they translocate. What we won't be able to answer through this research is, well, what size particles contain infectious SARS-CoV-2 virions? We can show particle deposition, say, in a distant from a room and say this is attributable to small particle transport. We don't know how small will matter. And that is kind of the droplet versus aerosol argument, is really just a question of how large are the entities carrying infectious particles. And that will need to be done through a different set of experiments. You can imagine in the Well Living Lab, it's we wouldn't be able to disperse even probably biosafety level class 1 type viruses, or I don't even think we would be comfortable doing that. And so we do work with these physical tracers. So that would be like the partner research we need. We can construct physical models, but we need to know where the viable viruses are.
Okay. And there's a sort of a related question from the audience. How do you assess the relative risk of airborne versus fomite transmission? What are the implications for existing built environments, both commercial and residential? And how are you examining the human factor, such as mask wearing?
So I can take a stab at that one too. Once if we had an answer to this, almost size distribution of particles or droplets carrying viable SARS-CoV-2, we do have really great physical knowledge on how to collect or how to understand the transport of droplets and particles of different size. So let's say we do find that overwhelmingly infectious virions are in smaller particles, that it really isn't a lot of droplet transmission, they are smaller. Then we can look at measures like increasing ventilation rates, improving the quality of filters in HVAC buildings, changing them out faster. So there is kind of a stack of knowledge already out there. In terms of what we're doing in Well Living Lab, we can understand how to do that transport in even more local level within the room. Masking, interestingly, we can do by simply putting a mask on our breathing simulator. Physically, it will do really the same thing that it would on a person. We're actually looking at two things. So if you look in the literature, you'll see a lot of information on the collection efficiency of masks. And there's concern when they say, well, it's not 100% collection efficiency. And it's not going to be, certainly for a homemade mask. But the second thing that masks do is they actually reduce velocities because even a leak actually does this. It spreads it over a larger area. And what that does is it reduces the kind of penetration distance of that person's breathing pattern, which is a good thing. It allows ventilation to do its work a little bit better. So we can assess these in the well living lab type environment by looking at how masks affect transport.
Great. What do you, could somebody comment on the approach to disseminating the findings? What, you know, sort of like, when do you anticipate you'll have something relevant to get out to the public in terms of the scientific findings? And how do you see that unfolding and the mechanism for it? I mean, there's rapid peer review literature, and then there's other ways to disseminate it. It seems like that's going to be, you know, not straightforward perhaps, and maybe a little bit stressful.
Yeah, so you know, as far as the timeline is concerned, I think that our surface disinfection with the VSV virus is likely going to be first out of the gate. You know, we're already drafting up the manuscript for that as we speak, because we anticipate that you know, that trial being done in its entirety in early December. You know, to your point about the dissemination of information, I think that's a two-pronged thing. We're already anticipating what you're talking about, Mark, as it pertains to the need to get this out quickly. And so, you know, when we think about academic peer-reviewed literature, writing what we can right now, which is the introduction, which is informed by our proposals and the methods, you know, that's something that we're already doing in anticipation of that. And then once you get the results, obviously you write the rest of the paper. But to the second point, and I'd actually love to hear Dr. Roget's thoughts on this. You know, there is different archives right now that are publicly available that are preprint essentially, and that might be another manner by which we're able to disseminate information. So, you know, Veronique, I don't know if you have any thoughts on that.
Yeah, I was afraid you were going to ask this, Zach. So I'll, you know, it's a really tough one. I mean, we've all seen the volume of scientific literature in the COVID-19 sort of world is unprecedented. The speed of publication has been unprecedented, and the volume of retractions has been also perhaps unprecedented. And so clearly, it's a very fine line that we would be walking with getting the results out so that the public can benefit without compromising science. And, you know, I don't have any you know, magic solution. I think before, I think the preprint is fine to think about using some of those preprint repositories, with which I want to be completely transparent. I have no personal experience, so we'll have to look carefully at that. I think if we, one of the many strengths of this multidisciplinary approach that we're following is that at least we'll benefit from having multiple eyes looking at the paper and heightened awareness, if you will, of the potential of really negative repercussions of a hasty and not completely checked out submission. So that's one thing. I think in terms of this, getting the word out fairly quickly in the scientific world. Now, I think, Mark, you were also asking about, now, how do you get this to the public? And, you know, again, that's not my expertise at all in terms of dissemination of science. And it's not something I have a lot of direct experience with. A lot of people talk about, you know, using social media in various shape or forms to get the word out. You know, that's about all I can offer. It's pretty generic and again, no direct experience with that.
I can perhaps take a stab at the couple other questions that are asked. So the most recent question that is asked is, to what extent do you think your findings about the best ways to reduce spread of SARS-CoV-2 in an indoor environment will also be useful in reducing transmission of other viral respiratory infections? So this is a great question. And in all countries that have the flu coming before us, and now the flu that is coming to us, they've seen a significant lower number of flu prevalence and incidence as opposed to before the times of COVID, because of measures such as distancing, hygiene, masking, most importantly. So in countries or in regions that are following these rules of masking, distancing, and hand washing, they have seen significantly lower number of flu cases. We will find out within this month and next and the month after if that holds true in our country. I hope so, but we will see what that shows. With regards to our findings, if even before our findings, if people in the public right now just follow simple measures like distancing, hand hygiene, and masking, that in itself will lower flu rates or other respiratory viral infection rates significantly, even without indoor findings of our research. And in the indoor setting, if you do simple disinfection of surfaces with soap water or even hospital or business grade disinfectant, that is going to significantly see lower rates of other respiratory viral infections. So that's to question one. And somebody asked an interesting question of pushing back against the disinformation that is going on in social media. As somebody, I do a lot of social media education as much as I can. In a world that is extremely partisan and polarized, I don't think it's going to work if you start fighting against people who do not listen to you. I think time has come to engage those people rather than say, that you're wrong and follow what I'm saying because I know better. I don't think that is going to work. It's time that we engage people who don't listen to you. And one way to do that is coordinated strategy through both scientists and policymakers. I think right now there's a discord between these two groups of people. I think Minnesota has done a decent job when it comes to mandating or at least encouraging masking in most settings. And I feel that other states should be doing that as well. And most other countries who have had a coordinated approach between the policymakers or the politicians and the scientists, with some amount of mandating to masking and rules of business like distancing, etc., or disinfection of surfaces, etc., have done a good job at it. So it's just having a coordinated approach and engaging people who don't listen to you and not telling them you're wrong and you're wrong because I know better. I just think that makes you two groups more polarized and more partisan. That is not going to work. So again, to summarize, I think there needs to be a coordinated approach between policymakers and scientists. And I hope we see that soon because we are seeing surges and understatement for the number of cases we are seeing now.
Thank you. So we're out of time. Zach, would you like to close it out? We really appreciate the great attendance this morning.
I would just like to first and foremost thank you, Mark, for the opportunity and really the whole division for the opportunity to present this work. Second, as you can see, this has required that multidisciplinary approach and really getting people in the room that are far smarter than I could ever hope to be. And so, this is really a testament to, again, and I know this sounds cliche and we've said it so many times, but the power of collaboration. And really for any health crisis, you do need that multidisciplinary approach, but definitely for something as timely as this, that's been hugely important. And we could not do it without individuals like Chris, Adi, yourself, Mark, as well as other individuals like Dr. Stacy Rizza, who was unable to attend today, but has played just such a major role in what we're doing. And obviously the countless individuals within the Well Living Lab and other individuals at Mayo who are making this possible. So thank you all again for this time. If you have any questions, I'll make sure, Mark, that I get you my information. I know you have it, but I'll ensure that anybody who has a question that they didn't get answered can get that answered.
Great. Thank you so much. Stay safe and well, everybody.
Thanks.
Thank you.
Thank you.